Most of us have felt a twinge in our chest at some point, a sharp poke that we dismiss as indigestion, a pulled muscle, or just the stress of modern life. We take an antacid, we stretch, we tell ourselves it's nothing. But for Donald Church, that twinge wasn't a muscle. It wasn't a cramp. It wasn't heartburn. It was a 13-inch long, solid steel surgical retractor, a massive piece of medical hardware the size of a ruler that had been accidentally sewn inside his body and forgotten. For 2 months, this man walked, talked, ate, and slept with a piece of surgical equipment pressing against his internal organs. He went to work. He came home. He tried to live a normal life while his body screamed that something was catastrophically wrong. His doctors told him the pain was normal recovery. They told him to be patient, to give his body time to heal. They told him he was fine. They were wrong. In the world of medicine, there is a term for this nightmare. It's called a retained surgical item, or RSI. It is classified as a never event, a mistake so fundamentally preventable that its very occurrence represents a complete failure of hospital safety protocols. These events should be statistically impossible in a modern operating room equipped with multiple counting systems, X-ray technology, and trained surgical teams. Yet, retained surgical items happen more often than you might think. An estimated 1,500 times per year in the United States alone. But the case of Donald Church is different. Usually, when we hear about retained surgical items, it's a small gauze sponge tucked into a body cavity, or perhaps a needle that's slipped into tissue. These items are tiny, easy to overlook in the chaos of a complex surgery. It is almost never a 13-inch metal tool, something so large, so obviously present, that its absence should be immediately noticed. Today, we're diving into the staggering negligence that occurred at the University of Washington Medical Center, the biological miracle of how Donald Church survived with steel inside him for 2 months, and the multiple system failures that allowed a massive piece of surgical equipment to simply disappear. The year was 2000. Donald Church was 49 years old, and he was facing one of the most terrifying diagnoses a person can receive: a large abdominal tumor. This wasn't a small growth that could be biopsied and watched. This was a significant mass sitting near his intestines and pressing dangerously against major blood vessels. Left untreated, it could have killed him within months, either through obstruction of his digestive system or by compromising blood flow to vital organs. Donald made what seemed like the best possible decision. He went to the University of Washington Medical Center in Seattle, one of the top-rated hospitals in the United States. This was a prestigious teaching hospital with cutting-edge technology, renowned surgeons, and decades of experience handling complex cases. If anyone could save him, it would be the experts here. He felt quite reasonably that he was placing his life in the best hands possible. The surgery was indeed complex. Abdominal tumors of this size require extensive surgical maneuvering. Surgeons had to carefully move organs aside, the intestines, the liver, the stomach, to reach the tumor without damaging surrounding tissue. To accomplish this delicate work, they used surgical retractors. Think of a retractor as a surgeon's third hand. It's a metal instrument designed to hold back skin, muscle, fat, or organs so the surgeon can see the surgical field clearly and work without obstruction. The specific tool that would haunt Donald Church for 2 months was called a malleable retractor, sometimes referred to as a ribbon retractor. This is not a small instrument. It's approximately 13 inches long and 2 inches wide, about the size of a standard ruler. It's made of solid stainless steel, flexible enough to be shaped to hold tissue, but strong enough to maintain that position under pressure. It is not the kind of thing you misplace. It is not easy to miss, and yet somehow it was. The surgery lasted several hours. The surgical team worked methodically, carefully dissecting through layers of tissue, isolating the tumor, removing it completely. From a technical standpoint, the oncological aspect of the operation was a success. The tumor was out. The margins looked clean. The surgeons likely felt a sense of accomplishment as they prepared to close the incision. On paper, everything looked perfect. The incisions were stitched up layer by layer. First the peritoneum, then the muscle, then the fascia, finally the skin. Donald was wheeled into recovery, still unconscious from the anesthesia. When he woke up, groggy and disoriented, he felt something immediately wrong. Not the expected burning sensation of a fresh surgical incision. He'd been prepared for that. This was something else, a deep structural pressure, an alien presence, like he had swallowed something solid that lodged itself in his core. He tried to explain this feeling to the recovery nurses, but they assured him that discomfort after major abdominal surgery was completely normal. Over the next several weeks, Donald Church's life became an escalating cycle of agony. He couldn't bend over to tie his shoes without feeling a sharp, stabbing sensation. He couldn't sit comfortably in a chair. Every position seemed to put pressure on something internal that shouldn't be there. Every time he took a deep breath, he felt a distinct poking sensation against his ribs, as if something inside him was shifting with each inhalation. He went back to his doctors, not once, but multiple times. "I feel something inside me," he told them. "Something hard, something that moves when I move." Their response was consistent and dismissive. "You just had major surgery, Donald. Your nerves are healing. What you're feeling is probably scar tissue forming. It's uncomfortable, but it's part of the healing process. Give it time." This is a psychological phenomenon that medical safety experts call dismissal bias or confirmation bias. Because the surgeons believed they had performed a perfect surgery, and because the count at the end of the operation had been recorded as correct, they unconsciously filtered out any data that suggested otherwise. Donald's pain, no matter how specific and insistent, didn't fit their narrative of a successful procedure. So rather than investigate further, they reframed his experience to match their expectations. They convinced themselves and tried to convince him that his suffering was normal. Meanwhile, something remarkable and terrifying was happening inside Donald's body. His immune system, recognizing the steel retractor as a foreign object, initiated a process called encapsulation. This is the body's desperate attempt to protect itself from anything it can't absorb or eliminate. His tissues began growing around the metal, trying to wall it off like the body would encapsulate a splinter or a bullet. Fibrous tissue formed around the retractor, attempting to isolate it from the rest of his internal organs. But you can't successfully encapsulate 13 inches of solid steel. The metal was too large, too rigid, too incompatible with living tissue. As Donald moved through his daily life, sitting, standing, bending, walking, the retractor shifted position inside his abdominal cavity. It pressed against his bladder, causing urinary discomfort. It pushed against his bowels, affecting digestion. It scraped against the inside of his abdominal wall with every breath. And here's the truly horrifying part. Donald Church was extraordinarily lucky that the retractor didn't migrate further. Had it moved just a few inches in the wrong direction, it could have punctured his aorta, the main artery carrying blood from his heart. That would have caused massive internal bleeding and death within minutes. It could have perforated his intestines, causing peritonitis and septic shock. It could have damaged his kidneys, his liver, his spleen. Every day that Donald lived with that steel inside him was a day he survived against probability. Finally, after 2 months of escalating pain, 2 months of being told his suffering was imaginary or exaggerated, 2 months of living with a foreign object slowly destroying his internal tissue, the pain became unbearable. Donald couldn't work anymore. He couldn't sleep for more than an hour without waking in agony. He returned to the hospital and essentially refused to leave until they took him seriously. The medical team, perhaps finally recognizing that this level of persistent pain was abnormal, ordered a CT scan. This should have been done weeks earlier, but better late than never. Donald was positioned on the scanner bed. The machine hummed to life, taking cross-sectional images of his abdomen. And then, as the images rendered on the computer screen, the radiologist saw something that stopped them cold. There, perfectly visible against the soft tissue of Donald's abdominal cavity, was a bright, white silhouette, the distinctive shape of a man-made object, not a tumor recurrence, not scar tissue, not anything biological. It was clearly, unmistakably, a surgical instrument. A 13-inch malleable retractor stretching from his pelvis up toward his ribcage, precisely where Donald had been insisting he felt something foreign. Imagine being that radiologist. You expect to see healing tissue, perhaps some post-surgical inflammation, maybe, in a worst-case scenario, evidence that the cancer had returned. Instead, you're looking at a piece of the hospital's own equipment, abandoned inside a patient's body for 2 months. The scar tissue that the surgeons had been so confident about was actually a massive steel tool that no one had bothered to account for. The medical team was stunned. Emergency meetings were called. How had this happened? How had something this large been missed? More urgently, how quickly could they get it out before it caused even more damage? They rushed Donald Church back into surgery. This time, the goal wasn't to save him from cancer. This time, they were saving him from the very institution that had sworn to heal him. The operation to remove the retractor was delicate. The surgeons had to carefully dissect through the fibrous tissue that had grown around the steel over 2 months. They had to ensure they didn't damage the organs that had been pressed against the metal. When they finally extracted the retractor, it was tarnished from body fluids and covered in the biological evidence of Donald's body desperately trying to heal around an impossible foreign object. So how does something like this happen? How do trained professionals forget a 13-inch piece of steel inside a human body? The answer lies in what safety experts call the Swiss cheese model, multiple system failures that align perfectly to allow disaster to pass through. The first hole in the Swiss cheese was the surgical count. In every operation, surgical nurses are required to perform a comprehensive count of every item that enters the surgical field. Before the first incision, they count every sponge, every instrument, every needle. At the end of the surgery, before closing, they count again. The numbers must match exactly. If a single sponge is unaccounted for, the surgery doesn't proceed to closure until it's found. On the day of Donald Church's operation, the count was recorded as correct. Someone looked at the instrument tray, saw what appeared to be all items accounted for, and checked the box. But clearly, the count was wrong. Either someone miscounted or they saw an empty slot where the retractor should have been and simply didn't notice. Or they noticed and assumed another staff member had already logged it separately. The second hole was high-volume fatigue. The University of Washington Medical Center is a major teaching hospital. Multiple surgeries happen simultaneously. Shifts rotate. Staff members hand off responsibilities to one another. During a long, complex surgery, the team composition might change. One nurse goes off shift, and another takes over. When this happens, the mental map of the operating room is lost. The first nurse might remember placing that retractor, but the second nurse, coming in mid-surgery, has no context. They trust the documentation and the counts from earlier, creating a perfect storm of assumptions. The third hole was what surgical safety experts call the closing rush. The most dangerous phase of any surgery is paradoxically not during the critical high-risk portions. It's during the routine closing. Once the complex work is done, once the tumor is removed or the repair is made, the psychological pressure releases. The lead surgeon often leaves the operating room at this point to speak with the patient's family, to give them the good news that the surgery was successful. This leaves junior residents or less experienced surgeons to close the incision. This is when objects most commonly get left behind. The glamour work is done. Everyone's tired. The adrenaline has worn off. The focus shifts from precision to completion. People want to finish and move on to the next case. And in that subtle shift of attention, a 13-inch steel retractor disappears into Donald Church's abdomen, and no one notices. Donald Church sued the University of Washington Medical Center, and unlike many medical malpractice cases that drag on for years with both sides battling over liability, the hospital settled almost immediately. They couldn't defend the indefensible. The evidence was literally preserved. A 13-inch surgical tool that had been photographed inside a patient's body on a CT scan. They paid Donald $97,000. Many people, including patient advocacy groups, argued that this amount was insultingly inadequate for 2 months of physical torture and psychological trauma. For perspective, Donald had lived for 60 days with steel inside him, experiencing constant pain, being dismissed and gaslight by medical professionals, potentially facing death every day that the retractor remained. But for Donald, the lawsuit was never about getting rich. He just wanted acknowledgement of what had been done to him. He wanted the nightmare to end. He wanted to move forward with his life. More importantly, Donald Church's case became what the Joint Commission calls a sentinel event, a medical error so significant that it demands immediate investigation and systemic response. This case, along with others like it, led to mandatory implementation of new safety protocols across hospitals nationwide. One of the most important changes was the requirement for radio-opaque markers on all surgical items. Now, even a tiny gauze sponge has a thin metal strip woven into it that shows up brilliantly white on X-ray. Surgical instruments are tracked with even more rigorous systems. Some hospitals now use technology similar to retail inventory management. Each item has a unique identifier that must be scanned in and scanned out of the surgical field. Many hospitals implemented a policy requiring X-rays before closing any high-risk surgery. If there's any doubt about the count, If there's any discrepancy, an X-ray is taken while the patient is still on the table. It's a simple step that takes 5 minutes and can prevent months of suffering. What's the strangest thing you've ever heard of being left behind in a surgery? Medical literature documents some astonishing cases. Surgical gloves, entire towels, pieces of broken instruments, and yes, even once, a surgeon's cell phone that fell into an abdominal cavity during a procedure. Let me know your thoughts in the comments below.